All right, good morning. It's a pleasure to be here with you so early in the morning. And some of you guys could probably use a little fluid bolus maybe this morning, huh? This fluid bolus that we're going to talk about today, this concept of preload responsiveness, this is the simplest intervention that we do for our critically ill patients. It's so simple to do. However, it's really one of the most complex decisions we have to make if we're going to be accurate about it. We don't want to withhold fluids for our patients who are critically ill. We'd like to fill the tank, if it's appropriate to do so, and improve their forward perfusion and help to restore cellular metabolism. But we want to withhold fluids for those patients who don't need volume. We know that it increases morbidity and mortality with fluid edema and inflammation. So it's a delicate balance, and we need a way to figure this out. So this is the concept. It's called legge del cuore. Does anyone speak Italian? Did I say it okay? Grazie, grazie. This is the law of the heart, and this is why we give a fluid bolus. Legge del cuore. It's discovered by Dario Masterini, who is an Italian physiologist, and in Italy they still refer to this in the textbooks as the law of the heart by law of Masterini. He developed this concept that we all know and we learn in physiology classes, and it's a beautiful concept. This is the notion that you can take a myocardial fibril and stretch it out to some optimal length by giving a fluid bolus, and we increase contractility. And so we give a fluid bolus, we increase the stretch, we get better stroke volume, better distal perfusion, the patients get better, and we have a happy ending. This is the law of the heart. This is the single reason that we should be motivated to give a patient a fluid bolus in our critically ill patients. Well, Dario Masterini didn't get any credit for this. A few years later, Otto Frank and Ernest Starling borrowed the idea from them, as many stories in medicine go. And so you know these gentlemen today who developed what we know now as the Frank-Starling curve. Now it's early, this is smack. You didn't come here to see the Frank-Starling curve. So what we're going to do is we're going to do this physiology in 3D. So I want you to reach under your chairs and take the 3D glasses that we taped underneath, and we're going to put them on. What's wrong, Cliff? My apologies. Apparently the opening ceremony went a little over budget, and there's no money left for 3D glasses, and I don't know if we really needed that flamethrower, but the things with the girls was nice. That was good, so maybe it was worth it. All right. Well, let's keep it brief then if we're going to talk about physiology. We have on our x-axis the thing you know, the preload, and then we have our stroke volume. When we give somebody a fluid bolus defined as 500 cc's of crystalloid, we expect a 10% increase in that stroke volume, and that is when we say a person is fluid or preload responsive. And we continue on giving that patient a test, a preload, a bolus, and we respond by 10% or greater than 10%. And we continue on this ascending steep portion of the curve until we get to a point where we give a fluid bolus and we don't see that response. So you can divide the curve into two parts, a preload responsive, or the area of preload reserve, or an area of preload independence, or where there's no reserve. And our goal is to stay on this green portion, the preload reserve portion. You know that different patients and different myocardial strengths have different curves. And that's just modified by individual disease states and individual patients. It's really summed up by Paul Marik, who has a really eloquent statement that says, when you have a hemodynamically unstable patient, give that patient all the fluid they need, but not one drop more. But that's our challenge at the bedside, is to figure out that one drop more. As we sit by the bedside for that critically ill patient and figure out which patients need volume and which ones don't. You can say our severely hemodynamically unstable patients, well, those are the ones that need volume. But when you look at the literature, only 50% of those people respond. 50%, it's a coin flip. This is better than your odds at the Jupiter across the street. But it's not good for your patients, and we don't want to be flipping coins in front of our patients. So we have this concept of preload responsive or fluid responsive, and this really divides up into two major categories of static indices of this measurement and dynamic indices. We'll start off and we'll talk about dynamic indices of preload responsiveness. Have a patient comes in hypotensive, our first instinct is to give that patient volume. And the emergency department, for many of the diseases, that might be the right thing to do, but you know that doesn't work for all diseases. Blood pressure is not a good correlate for preload responsiveness. These static measures are only one point in time. What you see is what you get with the patient. You don't know where they are on that Starling curve. You only know the end result. And hypoperfusion, that person can be anywhere on that curve. So giving a volume bolus for this person might not necessarily be the right thing. We go by the bedside, we touch the patient's feet and hands, we look for cool extremities, we look for capillary refill, dry mucous membranes, all the romantic things we know from medical school. But these are not good indices of preload responsiveness. These are static measures. This only tells us the end result, the distal perfusion. We need better measures than that. The call in the middle of the night of the low urine output in the ICU patient, our first instinct, give them some fluid because they must be dry being an ICU patient. But we know that's not correct. Not all low urine output is low intravascular volume status. Again, a static measure. What you see is what you get. You don't know where you are on that curve. Elevated lactate, SCVO2. You see where I'm going with this. These only tell us points in time and doesn't tell us anything about that particular patient on what we need to do for them with respect to fluids. And so, as I finished medical school and went on to training, I fancied myself as being this doctor who could sit at the bedside in this romantic picture and say, I can integrate all my history and physical into a cohesive plan and know what's exactly right for the patient. But as many of you know already, you cannot do this. History and physical fails us when it comes to this decision on whether or not to give volume. So we need other measures. And invasive measures have been around for a long time, and this is using intravascular catheters or intracardiac catheters to determine whether or not the person is volume responsive. Now, we no longer use routinely things like the pulmonary artery catheter, and we're getting away from things like the CVP. And the reason why is because this assumption that pressure is directly related to volume is erroneous. We know that it's not a direct relationship, and it gets modified within patients for certain patient-specific factors. It even gets modified within disease processes as patients present in the hospital. If you take this person, this elderly smoker, diabetic, hypertensive, he has a stiff, non-compliant ventricle, and he has a certain preload or certain CVP, if we're going to use that number. His CVP may be elevated, yet he may be volume responsive because we don't know where he is on this curve. And you compare it to this young athlete here, who has a very compliant ventricle, and he may have the same central venous pressure as the previous gentleman, but yet be volume overloaded. CVP is very specific to the patient that you have in front of you, and you can't know that just by looking at one number. Patients come in with diseases, chronic diseases. In this case, you have someone with pulmonary hypertension, cor pulmonale. This RV looks dilated when you eyeball it, but the CVP might be high, but this person may still be volume responsive. And as I said before, patients come in with different Starling curves. They come in within their diseases and change their Starling curves based on the therapies that we do and how they do. So CVP is a moving target, and it does not tell us where they are on the Frank-Starling curve. Mechanical ventilation, intrathoracic pressures, PEEPs, all these things that we do to patients alter these pressures. And so I hope I'm building up an argument that we're no longer using this. But if I haven't, this is maybe one of the best things that I've ever seen with regard to bashing the CVP. And that's this. If you have CVP on your y-axis, and you have the portion on the left here that tells you that the person has fluid deficit, the person on the right has fluid excess, you see this is just a big scatter plot of points. And so there's no CVP that really tells you whether or not this person is volume responsive or not, or it doesn't tell you anything about their intravascular status. In fact, you'd probably be better using a dartboard to figure out what's going on with your patient. It won't help your patients, but it might help you get ready for your trip to the pub after your shift. So I love ultrasound, and I believe it's one of the best ways that we have to determine not only some of the volume responsiveness aspects of patients, but also the disease physiology that patient might be presenting with. So I use it routinely on every critically ill patient. But when used this way in the spontaneously breathing person, it's also a static measure, so it has its limitations that you have to be aware of. If you take this apical four-chamber view and you look at this left ventricle, you might say that this LV is collapsing away. This person could require or could tolerate lots of volume. But you'll also notice that the myocardium is very thick And this is a stiff, non-compliant ventricle. And so you can try to give fluids, but up to a point that this ventricle will not be compliant anymore, and it still may look hyperdynamic. Take this parasternal short axis view, and initially you see this hypocontractile ventricle and this hypotensive person. Say, I think I'm gonna not give this person volume. I think I'm gonna go ahead with vasopressors or inotropes or a small trial of fluid. But you still don't know where on this person's compliance curve is. Perhaps they will respond to fluid. They may not respond as well to the young person whose ventricle's banging away. But this person may tolerate some volume. And then you have a case like this, an apical four-chamber with the left ventricle showing Takasubos, cardiomyopathy. Where is this person on their Starling curve? Does this person need volume or not? Half the ventricle is contracting and the apical part is not. It's a very difficult thing to eyeball at the bedside and make a determination of. IVC is another static measure in the spontaneously breathing person in volume responsiveness. You look at this IVC, and this person's IVC is collapsing down, saying that they likely would respond to volume. You look at this IVC and say it's big and dilated. Their right atrial pressures are probably high. This person would not respond to fluid. But what if this person has chronic pulmonary hypertension? What if this person has acute PE, a loculated diffusion, that you didn't see the full, classic echo textbook picture of that pericardial effusion saying tamponade? This person may respond to volume. But even if you accept that both these extremes, one requiring fluid, one you would never give fluid to, what would you do for your patient who sits right in the middle after the ED resuscitation and they show up in the ICU and they're day 2 and you decide you need to give volume? That IVC may be mid-range, and what are you going to do for that static measure of volume responsiveness? In the spontaneously breathing person, patients with asthma or emphysema, patients in respiratory distress may have very negative intrathoracic pressures, and that will collapse the IVC, giving us false information. Errors in measurement, if you're off the midline when you're measuring, or even if your patient's tachypnic and their IVC is moving in and out of your plane, it can be very difficult to measure. There's data showing that there's interrelator differences in reliability of the IVC. So measurements from one experienced person to the next may vary. So which measurement's right? There's also a fair bit of literature that shows that the IVC in the spontaneously breathing patient estimates the CVP. And we just got finished bashing the CVP. Now, many of you I know listen to Scott's podcast, and I mentioned this a little while ago, and I completely got bashed about it, so I won't go there. A year and a half later, people are still saying, did you hear Scott, how he got you on the podcast? So I'm not gonna go there. I happen to think that IVC can be helpful for you in the spontaneously breathing patient. I do. But it's a static index, and it has its limits, and we have to accept that. So again, these static measures, if you believe in them and if you want to use them at the bedside, great, but you have to realize that they really only hold true, or they may hold true at these extremes of measurement. So we see how static is what you see is what you get and has its limitations. Let's talk about something that might be better, dynamic indices. Now, dynamic indices are very accurate. They rely on the interaction between the respiratory cycle with breathing and how it affects changes in the cardiac preload. The only caveat with this, while they're very accurate, is it requires mechanical ventilation on your patients. So you can't take these dynamic measures to your spontaneously breathing patients, except for one example I'll show you at the end. And this is sort of the framework of how this works. When you have a patient and you insufflate the lungs and you increase your intrathoracic pressure with positive pressure, you decrease the venous return to the right heart, you increase the RV afterload, and essentially what you're doing is decreasing filling of the left side of the heart. In a few beats of that respiratory cycle, you'll see that the left ventricular ejection fraction will go down. When you release that breath, you're allowing filling of the right heart to occur again, and 2 or 3 beats after that release, you'll see an increase in the stroke volume, cardiac output. So the classic example of this is the pulse pressure variation, which many of you already use in the ICU, and many of your monitors already have this built in. It requires you to use an arterial line to make measurements of the tracing. And this is what we know as the swing of the A line. Many of you may see, or heard about, the A line is swinging, that person needs volume. And that's somewhat true if you have the right clinical conditions. So when you give positive intrathoracic pressure, you'll notice a few beats later at that maximum inspiration, you'll see a decline in that systolic peak and that pulse pressure. And when you release that breath, you'll start to fill the LV again, and a few beats later, you'll get an increase in your stroke volume. Even if you didn't want to remember any of that, just take one respiratory cycle and take the absolute pulse pressure from the maximum deflection and take the minimum one and plug it into this formula. Or if you have the monitors, it'll do it for you. The maximum minus the minimum divided by the average, and the magic number here is 13%. And what that means is that if your pulse pressure is greater than 13%, it means your patients probably need volume, and go ahead and give it to them. And if your pulse pressure is less than 13% and they're hemodynamically unstable or hypotensive, go for other therapies and withhold the fluid. Conditions have to be perfect if you're using pulse pressure variation. Patients have to be in sinus rhythm, right? All our patients in the ICU are in sinus rhythm, right? Normal abdominal pressure. Any increase of intra-abdominal pressure or increased thoracic compliance or decreased thoracic compliance can actually alter this measurement. There can be no right ventricular dysfunction. Patients have to be synchronous with the vent. They can't be breathing above because any negative intrathoracic pressure is going to alter that positive pressure interplay. Patients have to be receiving 8 cc's per kg while you're doing this test. So this is a little bit of a variation from our 6 cc's that we try to do. And PEEP has to be moderate, and the studies really don't define this, but anywhere between 5 and 10 of PEEP. Any higher, and you can alter the results of this test. So you can use the inferior vena cava in the mechanically ventilated patient for something called Distensibility Index. And what you're doing here is you're noticing the change in your IVC diameter with respirations, or with mechanical ventilations, I should say. And as we said before, when you have a positive intrathoracic breath, your IVC will get plethoric as it can't return blood back to the RV. And when you release that breath, it goes back to normal size. And it's the amount of variation that you're going to measure. Now, it might be a little bit hard to eyeball or freeze, so you can use something like M-mode. They'll track this IVC in time, and you have to be careful about the measurements. But essentially what you find here is you find the normal IVC size, and within that same respiration, you find an increase in the IVC diameter. And two formulas you might see, and I recommend only picking one, is the maximum minus minimum divided by the average, or the maximum by the minimum divided by the minimum. So the denominator changes. If you use the minimum as the denominator, greater than 18% tells you that this person should get volume, and less than 18% says hold volume for now, there's no need. If you use the average as your denominator, then 12% is your magic number. And you might start to see a trend here with the numbers. We're looking at numbers that are really between 12, 13, 15%. So you can even pick one number and stick with that if it's too many numbers to remember. Here's some examples where you measure out the IVC along respiration, 84%. Give this person volume. Contrast this, which you can almost eyeball here, but when you measure it out, 4% Distensibility Index. Don't give this person volume. Before you get too excited about this, you have to realize that the same limitations for pulse pressure variation occur here too, meaning that the person has to be in sinus rhythm, normal RV, not breathing above the vent, and 8 cc's per kg. These same things that happened for before must be happening here, because it all depends on the interplay between the cyclic variations of the respirations and the heart. Subaeric peak velocity, it's sort of like looking at the pulse pressure variation, but what we're doing is we're looking at the velocities coming out of the LVOT. So you're going to get an apical 5-chamber view, which is a 4-chamber just tilted a little bit anteriorly, to see the 5th chamber, the LVOT, and you're going to put a pulse wave Doppler in there. And you're going to track out through time and see all these little icicles that are hanging down from the ceiling. And we're just going to put the dots on the tip of these icicles within the respiratory cycle. We take it on the largest and smallest, and we plug it into our formula again. Magic number here is 12. If the variation is greater than 12, give that person volume. If it's less than 12, you can withhold volume. Some examples, this person has 27% variation. You know to give them fluid in the right clinical setting. This person has 9% variation. Look for other therapies in this hemodynamically stable patient. This one, if you just eyeball, it looks pretty close. It tells you that there's 17% variation, so you still have some room to fill this person's intravascular volume. What do you think the limitations are here? It's the same limitations as before. Sinus rhythm, synchronous with the vent, 8 cc's per kg. You see where I'm going with this? Well, there's this newer test called the end expiratory occlusion test, and this is sort of like the suffocation test. Because what you're going to do here is your patient who's mechanically ventilated, you're going to disconnect them from the ventilator or hold an end expiratory pause for 15 seconds. The patients need an A-line, and you're going to look for a variation of the pulse pressure by only 5%. The reason why this is a good test is because patients can be breathing above the vent, as long as they're not very tachypnic, and patients don't have to be in sinus rhythm. So this applies a little bit more to the patients that we might be taking care of. So keep end expiratory occlusion test. Again, 5% change in that pulse pressure variation, and if your machines do it for you, there's no calculations at all. The final dynamic indice I want to talk to you about is called the passive leg raise. Now, the passive leg raise is great because patients don't have to be mechanically ventilated, they don't have to be in sinus rhythm, and it's an autologous fluid bolus that you're going to be giving your patient. So what you're going to do here is you're going to sit the patient up 45 degrees, and you're going to take a measurement of stroke volume of the heart, and I'll show you how to do that in just a moment. And then you're going to take their legs, tilt them up 45 degrees, and what's going to happen here is a 300 to 400 cc bolus from their lower extremity veins and their intrapelvic organs are going to go down back into the heart, and you're going to see whether or not there's a change in the stroke volume. And we're going to test that again with bedside echo. Of course, you can use this with non-invasive monitors if you have that available at your institution. But the best part about this is this person is not volume responsive. You just tilt their head back up, and the blood pools back into their lower extremities. You can also do this if you don't want to passively leg raise or there's any contraindications. You could give this person a volume bolus. But the important thing here is to measure before and after to see if there's been a change. So very briefly, this is how you're going to check for the change in stroke volume. You need two views of the heart, and the first view is the parasternal long axis view as shown here. The assumption here is that the LV is actually a cylinder, and this cylinder flow is equal to one stroke volume. And this stroke volume goes through the left ventricular outflow tract through the aorta. So all we have to do is solve for the volume of this cylinder. Now, this sounds a little bit hokey, and there's a lot of assumptions, but this actually seems to hold true when you look at studies that correlate the stroke volume with this cylindrical method. So we need to solve for the width of the cylinder and the height of the cylinder, two things which are relatively simple to do. To measure the width of the cylinder, we're going to take the parasternal long axis view, and we're going to freeze frame mid-systole and zoom in on that LVOT. And we're going to make very careful measurement here about the width, which is the left ventricular outflow tract diameter. This is the width of our cylinder. The next step is we need to see the height of that cylinder. And what we're going to do is we're going to solve for what's called the stroke distance. Every red blood cell per beat travels a certain distance before it gets pushed on again the next systolic cycle. So we need to solve for that stroke distance. And the way we do that is we use the apical 5-chamber view here, and we put that pulse wave Doppler, as we did for the subaortic velocity method, and we trace out these velocities. And we take a couple of these velocities, and we trace around, and what we get after that is called the velocity time integral. Now, it's not important for you to remember that this is an integral, but when you trace around, your machine will spit out a value that's actually a distance in centimeters, and that will be the height of your cylinder. So now you have everything you need. You have the width of the cylinder, the LVOT, you have the height of the cylinder, the VTI, and there's apps and there's calculations, and your machines may do this, but this will plug out a volume of that cylinder, which is essentially the stroke volume. And we're looking for a change in stroke volume of about 12%. So if you do your passive leg raise and the person responds by 12%, this suggests that you can go ahead and give exogenous fluids. If you don't feel like doing the passive leg raise, you can go ahead and give them a little fluid bolus, but track it along with this and follow that stroke volume as they lay recumbent and you give them that bolus. So these are the dynamic measures of preload responsiveness. Clearly, not all our patients fit into this mold of dynamic measures, and it's also a much more difficult test to do. So here's what we have. We have two tests. One that's not so good, but easy to do at the bedside, and one that's very precise and accurate, that's more difficult to do. What are we to do at the bedside? And this is really where the art and the science of medicine comes together, because I believe you need both these measurements at the bedside. If we went to everyone in this audience right now, not because of karaoke last night, but we did passive leg raises on you, most of you would be volume responsive. And most patients are volume responsive because we have this preload reserve. This is just naturally what we have. So to do a passive leg raise on every patient that you have in the ICU, even when they look well, doesn't mean anything. But static measures are sort of like our pretest probability. So if we look for patients who have dry mucous membranes, cool extremities, decreased urine output, and we say that those patients may be volume deplete, it should guide us to do these more precise measurements, the science, like dynamic indices, and determine whether or not that person should get a volume responsive. So it's more like a pre-test probability with our physical exam and a dynamic test at the bedside to confirm, so that we're ensuring that we give our patients the optimal amount of fluids and not one drop more. So with that, I want to tell you that it's a complete honor to be here, not only just attend the conference, but to speak to you. And I've learned a tremendous amount speaking to you. So with that, I want to say thank you so much for your time.
Natalie, have people been using their Twitter machines?
Yeah, there's been a couple of questions for you, Haney. There was a question, let me just find out who it was from, about the best way to assess hemodynamic status in the pre-hospital setting where we don't have the options for invasive monitoring, so kind of make those early pre-hospital decisions.
That would be a good study to do, maybe a pre-hospital study with maybe something like passive leg raise, or perhaps assessing with ultrasound and giving a fluid bolus. You know, I realize the limitations of passive leg raise, and let's just be clear, we can't, not all our patients, we can just for every fluid bolus hold their legs up in the air and make decisions. It's just not that simple of a decision. But if we choose a smaller volume and test out before and after we give that volume, I think that's fair. So I've talked to several of the pre-hospital people here, and you guys are really advanced, so I don't see a reason why something like ultrasound couldn't be used.